the point of this is really to get like-minded peers together and really have this be interactive, and so that we can learn from each other, learn kind of what's working and what's not. As you know, everybody on this call probably is thinking about, how do I not only survive but thrive in both of these worlds, which are more and more overlapping, the fee-for-service world and the value-based care world. And we're going to try to keep this pretty light, interactive, and the goal is to answer your questions and to encourage good discussion. So really encourage you to speak up.
I believe we have a question actually from Eugene.
Oh yeah, hi Eugene.
Hey guys, one of the things that I wanted, was hoping that would come out in this is how to get physician buy-in when you're utilizing third-party vendors to address this lack of resources to apply value-based care. So, you know, the one that probably everyone's heard about is chronic care management, where you have physicians saying, oh, we can do that, oh, we can do that, but they don't have the resources to do it. Mm-hmm. You bring in a third party, but you still have providers that haven't bought into the methodology. And it's more of a business construct than it is really a clinical construct.
Mm. Yeah, that's a wonderful question, Eugene. You hit on two very important topics there. One is, as you said, lack of resources, right? And we're going to dive into that and go through some numbers there. And then number two, of utmost importance, is that the providers have to know what's going on, and they have to be bought into the concept. So we will absolutely get to that. And Ben, just do me a favor, if I forget when we get to the that stage of this, just remind me.
Yeah, for sure.
So I think now we can get started. So we've got a good crowd here, and Ben, if you want to share the screen here, we'll jump into it. So by way of introduction, my name is Darshan Bachawat. I'm the Chief Revenue Officer at John Health, and our solution is called Family. Our customers and partners know us by Family. And just so you know kind of where we're coming from, we are the leading text-based chronic care management platform in the country. And we work with quality and growth-oriented medical groups, hospitals, and health systems to enable them to do high-quality, proactive care management at a very large scale, at a scale that just isn't possible through traditional means. And this hits on Eugene's questions about the resource constraints. So that's a little bit about us. We work with multi-specialty practices, primary care practices, various specialist groups, hospitals, health systems all across the country, in rural settings, urban settings. We work with FQHCs, rural health clinics. So we've got a bunch of experience working with all different types of clients and all different types of patients across the country. So really happy to be here, and appreciate each and every one of you taking time on what I'm sure is a busy week for you. And the topic again is this journey from fee-for-service to value-based care. Ben, if you want to move forward here, and really engaging in a discussion about what you all are doing now, and what are some of the things that can be done as you think about how to make this journey. And I know that, you know, across the country, in various clients that we work with and speak to, people are in various phases of this journey. Some people are in a place where they're majority value-based care. They're in, you know, next-gen ACOs. They're in very more advanced risk-sharing agreements, where they're at risk for really the whole health of a patient population. And then there are some that are just starting this journey, where they are, you know, vast majority in fee-for-service. They might have some value-based components of their contracts, but they haven't really jumped into the deep end. And our core hypothesis here is that one of the reasons this journey is difficult is because in the fee-for-service model, our entire care delivery system has been built on the idea, especially when you think about providers on an outpatient basis. The entire delivery system is built on the idea of patients. And let's take, for example, if we take the Medicare population, these Medicare patients on average are seeing their providers about 4 times a year. And as we all know, 75 to 80% of Medicare and the Medicare Advantage population are living with 2 chronic conditions. And they're living with those chronic conditions 365 days of the year. So for 99% of the year, and for the vast majority of these patients, in our current system of care delivery, those patients aren't getting any support and nobody checking in with them for those remaining 361 days of the year. And that system we've been using for decades. Providers are used to it, medical groups, hospitals are used to it. And now, more and more, you all are responsible for taking care of a population of patients, and in some cases, are responsible for the total healthcare cost of that population. And that disconnect of we're in a system where we're just used to patients coming into the office. That's when we take care of them, when either maybe it's a wellness visit or an acute visit, but it's a couple times a year. But 99% of that patient's life and their healthcare happens outside of those office visits. But our system isn't set up to do that, our fee-for-service system. And that's part of what makes this transition difficult. The other part is for folks that are in these value-based care arrangements, the typical approach to how do I manage this population is to hotspot, and in this case, we're showing, for example, your top 5% of patients that are the highest cost, that are at the highest risk of ending up in high cost settings and are high utilizers. And for that very small segment of the population, having care management FTEs trying to do manual and traditional care management for those patients, which typically involves phone calls. Maybe there's a multidisciplinary team that are taking care with very manual and labor-intensive efforts, a very small segment of the population. And that's number 2, which is that works, that intensely human labor-intensive approach, if you're only doing it for a very, very limited number of patients. But as you start to engage in these value-based care contracts, whether it's, for example, with shared savings, where you've got a much larger attributed panel, the question is, how can you expand the scope and scale of that proactive care management you're providing to a much larger population? And when you think about the numbers, typically we hear that a care manager doing care management for a group of high-risk patients, they're able to do it with a caseload of perhaps 1 to 100. And when you think about how do you do that for thousands of patients or tens of thousands of patients, under the traditional model, you would have to hire dozens or hundreds of care managers, which we all know, not only in this environment with staffing shortages, but from a financial perspective is not doable. So those are 2 challenges I really want to focus on, which is we've got a delivery system which is not built to take care of the whole person's health 365 days of the year. And then our traditional care management approaches are meant only to take care of a very small segment of the population. I want to dive into both of those. And Lisa, since you're on, I would love to hear your perspective as you think about that journey or that transition, which albeit might be slow from fee-for-service to value-based care. What are some of the other challenges beyond those 2 that I mentioned that you've run into and that you think about solving?
More from a big picture standpoint, or, we could even jump into, was it Stuart that asked the question about the engagements, the resources? I mean, we've run into all of them.
Mhm.
We really identified physician champions because if you're going to engage with their patients, having a provider that's supportive and basically my right hand at reviewing care plans and things like that to get the physician buy-in has definitely helped us be successful with the physicians. I still think that that's a slow and organic process because the physicians don't quite understand. I think a lot of people are really struggling with care transformation. What does that mean? Because we're delivering care. It's just not necessarily, we're not doctoring every single patient. They don't need doctoring all the time. And that is a challenge to get beyond. Sometimes it's just a question on, I went to go pick up my meds and they're too expensive. And it's a quick message to the physician to change those things. So I would echo the physician buy-in. I've done a tremendous amount of education to the providers. I would say the other big challenge I'm facing right now is conducting outcomes analysis, because everyone wants to know what you're doing is working. It's not just about creating the revenue. It's really about making that impact on the patient's journey from a health standpoint. And our other big hurdle that we're in the middle of jumping over every day is social determinants of health, and how people's lack of access to resources are massively impacting their health outcomes. And we're just beginning to scratch the surface, but because we have the texting and all the standardization and the workflow design and partnership with family, we're able to screen our patients very easily and quickly and identify those people who really need additional focus. So patient buy-in, that's a struggle for us. I think Medicare is finally realizing they need to spend some time educating the beneficiaries on what value-based care is, because the beneficiaries have no idea what this is. And so, one of the downfalls, I guess, that you could say, of CCM is the patient actually has to agree to be in it. And then they have to agree to be billed. And then there's subject to cost sharing. So it's like there's still barriers, but we didn't want those current barriers to be a reason to not start. And so we've just kind of dealt with those as they've come up in partnership with my team from family. And, we're still maintaining high levels of success in that area.
Lisa, great points. And I want to just dive in a bit to the physician engagement question. So talk to us a little bit about that, and definitely open, Lisa, to your perspective here, and also the folks at Coleman. As you've been communicating with your physicians in terms of the need, what is the need to have more proactive check-ins, touch bases with these patients as you navigate this journey? What is some of the pushback that you've been getting from providers? And what are some things that have resonated? Would love to hear from either of you.
So pushback, and I think that's definitely slowing down. I would say within the first 6 months, it was much more frequent. I don't know how, I hear I have a PHO spirit animal on the phone, but I don't know how you guys set up your program. The way I structured mine is I hired dedicated medical assistants to just do this. And I was able to work with family to create a financial model to show one medical assistant can generate X dollars of revenue. So I was given the okay to hire the person up front and then get the patients enrolled from there. But family went much faster than I could hire. I mean, within the first several weeks, we had 1,500 people that wanted to be engaged. So, creating those models so that the folks that give the approvals on the hiring, you know, can give those up front. So that was, you know, something that's worked well for us. Partnering with the physicians when something would come up, like a patient reported a very high blood pressure, which was very alarming. Keeping the provider engaged as we were dealing with that situation in real time. And then using that example to share across, I tell stories to my doctors like at least once a week. I grab a patient example. My team has a daily safety huddle, and we created like a virtual worry board. So if anybody needs to be on the worry board, like I get alerted, the office managers get alerted. So we have very structured daily safety huddles so the physicians are brought in when it's appropriate for their intervention, or at least the awareness. Our staff also works directly in the medical records. So to the question about the third party, the only third party situation we have going on is the technology piece. The staff is ours. So I think that was helpful in getting over the hurdle with the physicians. It's our own medical assistants that are trained in our processes and policies and care algorithms and things like that. They sit in our medical record, but they also sit in family. I have them set up with dual screens. And then our providers get messaged when it's appropriate. And that was even like, how much do you want to know, doctor, versus like, I'm not going to tell you they're in the backyard stretching to get into the garden without hurting themselves. So we developed these escalation criteria, so to speak, for the physicians on what they felt was things they needed to get involved in. And that's been really successful in kind of quieting the noise, if you will, with the providers.
Yeah. That's wonderful. If I were to summarize it, and Eugene, would love to hear your thoughts here. And if this starts to get at the question that you posed, I take away three things, Lisa, from your great description there. One is the providers, educating the providers on why the frequent and consistent outreach to their patients matters, and how much is going on in these patients' lives, including the social determinants of health that Lisa mentioned, when they're not in your office, and the impact that can have on their health outcomes. And I know Lisa has done a really wonderful job sharing those stories with providers again and again. So that's one that I took away. Two is, Eugene, to your point about third party, the way I know Silver Cross, for example, Coleman is on the line, the way they've structured these teams is really as a service line. It's a dedicated chronic care management team that is responsible for delivering high quality care to these patients. And so that gives the providers comfort that this is not some third party call center calling my patients. These are folks that are my colleagues, right? They're employees of the same organization. And I've worked with them to develop the content and the workflows. And that leads to number three, which is that care coordination. When that centralized team is working with these patients and there's a case of an acute issue or clinical escalation, that provider knows exactly what to expect. If this happens, it's going to come to you in this way. Here's what we need you to do, right? And you don't have to worry about all the rest. So those are the three things I took away. But Eugene, would love to hear your thoughts in terms of the provider buy-in vis-a-vis the third party, and see if any of those thoughts were helpful, or if there's other challenges that you've seen.
Yeah, I mean, I would say all of this is very helpful. Certainly having your own teams, you know, that are your employees, that's probably the gold standard if you can achieve that. Mm-hmm. I deal with a lot of ACOs though, and many of our members don't have the resources, either don't have the resources or can't find the resources. So, right. You know, so they have to go external. And certainly, you know, the technology is what is almost essential to do the care coordination and then the patient engagement, because it's that engagement that really drives adherence to the care plan, whatever it is for the patient.
Yep.
But for me, when you really dig into a transition from value-based care or to value-based care from fee-for-service, the number one issue is how to replace the revenue.
Mhm.
And where I fall more and more is that especially in the primary care setting, you cannot leave any dollar on the table. And so CCM is obviously a really great one because it's something that you can access the revenue and as you've already said, you can engage so many more using the technology. You can engage so many more patients, right?
Yeah.
But there are other things that you can't leave on the table. A great one is allergies, for example. There's a big trend now towards moving that allergy engagement to the PCP, but it requires, in many cases, a third party to come in and provide services to the patient within the PCP setting. But it's driving revenue to the PCP, and that for me, that's just one example, right? There's many, many, many more that are absolutely required because you can't ever break from the fee for service unless you can replace the revenue.
Yeah, no, I agree with you, Stuart. I mean, one of the things that Nabil helped me with is so we're in an enhanced track, MSSP ACO, and I took the data that was out there from CMS to say, this is approximately the ROI on care management. And I took my total Medicare spend on my, 5,000, I have a total of 11,500 attributed lives in the ACO for Medicare, and 5,000 of them are in my employed physician group. So I took the total spend there and applied the ROI mathematically and spit out and said, hey, I'm going to generate revenue doing CCM, getting all the quality measures met, because I can take those quality measures and apply them to the profiles and family by tagging the patient to say, hey, AWV status, breast cancer screening, depression screening, et cetera. So the care managers are constantly working the quality measures for that patient, which generates incentives at the other end. So not only are you getting your fee for service revenue just to keep the program afloat and you're making some money off of it, then you're chasing down your reduction in spend, which is actually just a lot of wasteful facility care, right? Like they end up in the hospital or the ER because they don't know where else to go. And, we all know what's going on with hospital beds around the country. Like, people are sicker and sicker now because of COVID, and they're staying longer and longer, which is actually hurting the hospitals financially. So we're working on better managing them up front and chasing the opportunity dollars in the ACO contract. So that's something that we looked at, and we're kind of measuring ourselves against that to see how we're doing there. And on locating resources, I actually was able to get approval to start this team to work remotely. And I'll tell you, I had zero problems hiring medical assistants because they really don't have any jobs out there where they can work from home. They are supervised by a nurse, so I don't have them on an island by themselves. But we've even developed, along with developing new care delivery models, we're developing new employment models, because I'm now able to hire medical assistants to work from home as adjunct staff, and then they just go into the physician practice once a month, twice a month, and meet with their providers, so they have a relationship with the office. They're just not physically there every day. And I did that on purpose because I didn't want that, like, hey, Deanna, Sally called off today, I need you to head out to the floor and start rooming patients. These staff are nowhere near the office unless they're going in to meet with a patient, going in to meet with the provider. So their 100% focus is time spent for chronic care.
Yeah, wonderful points. And I want to get back to the resources point and the staffing point, and how to think about those in more detail. I had noticed
it was
Julie.
Julie, if you had a question, sorry, we took a minute to get to you. If we could, if you're still on.
Sure, no, that's no problem. I just kind of wanted to echo what Lisa had said. It was very obvious to us that we needed to make our chronic care team work remotely in the beginning because of all the distractions in the office. And in terms of the pushback that we had gotten, one of the ways that family allowed us to be able to address that is just the sheer scalability that we have with family. The physicians, we had looked into CCM before, and the physicians, one of the first things they had asked was, why is it different now? Why do we think now we should do this as opposed to a few years ago when we looked at that? And the platform enabled us to have that scalability that you just couldn't get without that technology. And so we've kind of done the same thing that Lisa mentioned. We've sold it as family just being a technology platform and not really as a third-party resource. And I think that's been beneficial in terms of the physicians being able to adopt that better and embrace it more fully. Another thing that Eugene had mentioned in terms of the being able to sell the physicians on the idea of this is I don't know how you guys are set up, but we're a productivity model. So on our compensation spreadsheet that we do quarterly, I added a line item for incentive money so that we can see all of the incentives that we're getting from the Medicare Advantage plans. And that actually helps us quantify the work that they do, that extra work that they do. And the other thing that we did was we invested in a quality assurance coordinator, and her primary responsibility is the data gathering and communication, making sure to assimilate that data to the correct people so that we can assist with gap closures. And the CCM team, we've got a great CCM team with Stephanie and Sonia. And, all of these resources together are going to help close those gaps and meet those quality measures, which translates to dollars. And like somebody mentioned earlier, you can't leave a single dollar on the table. So those are just a couple of the things that we've done to help with the pushback that we've seen from our physicians. And another thing that we're planning to roll out here in the next month or so, we're still fairly new to family, but we're going to start rolling out some remote patient monitoring as the CCM team is identifying those patients who would benefit from a home blood pressure monitor or a glucometer. We're going to have those devices sent out and start managing the RPM piece as well. So I'd be curious to know if anyone else has had experience with that and what it's been like.
Not yet, but I'm right there with you. I think I'm looking at my Q1 is October 1st of, the way I look at it is CCM is the foundation to the house. And then each patient might need to live in a different room. Not everybody needs remote monitoring, but they might need it here and there. So that is something that I'll be looking at coordinating. One of the other things, Julie, I have my team doing is in my population health analytics platform, I have the Hopkins predictive modeling algorithm so they can see who our high risk patients are and things like that. And I just teach them, like, this is where patients fall in the cracks. They get out of the hospital, they're COPD, they're CHF, they go home and they don't have a lot of resources, or they don't understand their discharge plan. They can't get to the pharmacy, et cetera. So we're on them, like almost like transitional care management, but we're just doing it through CCM. The patients are texting us when they're in the hospital and they're querying the physician, patient presents with blah, 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 blah. Would you feel in a palliative care consult's appropriate? And I formulated partnerships with outpatient palliative care companies that are on that value journey as well. And so we have built this sort of network of preferred home health, preferred palliative companies. And then my CCM team is really the nudger to the physician, if you will. I think this patient might benefit from additional services. And then the physician agrees, writes the order, and then we take care of getting all the referrals set up. So that's been really successful in identifying those patients that might be falling into the cracks.
Great. I have one follow-up question for Lisa and Julie on the staffing piece. So Lisa made a wonderful point that rethinking how we think about staffing and enabling folks to work remotely has really opened up the spigot and has enabled Lisa, and I know many of the folks that we work with, to fulfill their staffing needs. That's one. We also see in our data and hear anecdotally from the folks that use our platform and take care of these patients that they find the work very meaningful. And by using the right tools, they're able to spend more and more of their time actually taking care of patients and engaging patients, and less of their time making robotic phone calls or documenting manually. And I think that's part of being able to fulfill those staffing requirements, is helping people understand this is a really meaningful role. But I'm curious from either of you, have you had that experience? Has your staff enjoyed the work?
I don't want to speak for Stephanie. She may want to chime in herself. She's on the call as well, or Sonia for that fact. But I know, just as I'm hearing Stephanie talk with other people about what she's doing, I can hear the passion in her voice. So I think that they are enjoying what they do, because nurses go to school and CMAs go to school to take care of patients. And unfortunately, in primary care, at least, a lot of what that job now entails is being an insurance clerk, it's doing PAs, it's so much of that is no longer actual direct patient care anymore in the primary care setting. It's paperwork. And this allows our CCM team to be able to get back to that original calling, and that is taking care of patients. So again, Stephanie and Sonia may want to chime in for themselves, but just being on the outside looking in and hearing Stephanie at least talk about what she's doing, I can hear the passion in her voice. So I think that she's enjoying it.
Right.
Yes, I would have to. This is Stephanie. I would have to just tell Julie, I'm a registered nurse and I'm the lead for our CCM program, and we have a CMA, Sonia. And it has been so wonderful for us to be able to communicate with the patients. But the main goal, like you said, is to see if we can catch this and give the information to the physician ahead of time, because our patients are in need. And that sometimes a lot of patients feel like they can't get through on a phone system, or they had to leave an extra message and it's not exactly being taken care of immediately. Where here, we're just sitting here focused on the patients and their care, and we can respond and we can triage quickly on which patients need this information sent over to the physicians. And so it has been a quite meaningful job for us. I came from a hospital setting back to, to a clinic setting. So this hands-on experience is really through the family platform, but we're still doing that patient care, just like we are physically triaging them. We're doing this with a program, and we can send that information over to the doctor, and the patients are staying out of the hospital. We've caught quite a few just in the past 7 weeks, I believe, that we've been using family and keeping the patients out of the hospital, because it was something that the physicians get taken care of, even when through our walk-in clinic, go to our walk-in clinic and be seen, or they would have rather gone to the ER at the time, thinking that's the only option they had. And so that was prevented.
Right.
So thank y'all for that.
Yeah, I agree, Stephanie. I think, there's just this general misconception that people know how to be healthcare consumers, and they don't, and they're in need. And they're just going to go where they can get access. And if we can provide that access, I think all of my staff has echoed what Stephanie said, just to be able to feel like that connection. I mean, I've heard stories where my care managers downloaded the same app as the patient, and they went into a walking challenge together. So now I have my staff engaging in healthy behavior and teaching patients how to be healthy, and preventative care. Providing dietary recommendations to help limit patients' GERD symptoms. And now we're helping people understand the importance of plant-based diets and nutrition. That is a tremendous lift, and getting people to change behaviors is very challenging, and nudging them towards those healthful behaviors. It takes that relationship. And, we've had patients disclose to us that we're like the only people that check in on them every week. Like, they don't have family, they don't have friends. And it just really has, broken that barrier of loneliness for thousands of our Medicare patients. So I would say that our staff feels the same way, that they really feel like they're making an impact in the patients' lives. And, patients are saying, like, they feel like that old school relationship with their doctor, where the doctor knows everything about them now. And so it's been really positive on our end as well.
Yes, Lisa, I have to agree with you on that. And another thing with the platform that we just really love is that like today we had our regular meeting with our family team. And so we're going to send a check-in today that is specifically designed. I asked them, they haven't even created it yet, but from one of their templates is that we're under a heat advisory. And in the South, in a heat advisory with 107 heat index, our Medicare age patients, they're going to get out there and mow the yard with a hat on, with long sleeves on and pants. And then they're the ones that's going to be at the highest for a heat stroke. So our message that we're going to send out to them is, you know, be advised that we're under a heat advisory, because a lot of them do not know that. And then also, are you drinking enough to stay hydrated and to try to keep them out of the hospital right now? So that's what our goal was, is just trying to something that's environmental right now to make sure that our patients are taken care of.
That's great. I may have to steal that one from you. We did one for a snowstorm, and we told all the patients, don't risk driving. We'll flip you to telehealth. If you still need to see your provider, don't abandon your appointment. So we were able to keep all the physicians' appointments for patients, so that they didn't have to, one, lose the revenue for the patients that day, and two, risk putting the patient on the road for something that could be handled over telehealth. So I really like that idea, Stephanie. That's great. We're under a heat advisory in Chicago too, 105, I think, today.
Yes, ma'am, we understand. And then last week we did have a glitch that AT&T had our phone systems down on Monday and Tuesday at the office. And what a blessing it was that we had all of our CCM patients, because they were messaging us and we were able to continue care and still message our providers, but they didn't have a phone system to know that patients were calling in. So that was even a blessing, being a remote worker.
Definitely.
Stephanie, some really interesting points you made, and I know we're running short on time. I just want to dig into one with you, and Lisa and Julie might have some thoughts on this as well. You mentioned in the last 7 weeks, you've seen some episodes where you believe you've been able to direct patients that would have ended up in the ER or the hospital to a different care setting. And the question that comes to mind is, if I'm in your all shoes, or maybe the provider's shoes, I'm thinking, well, even without this, these patients know how to get in touch with us. They can call us. Coleman has walk-in clinics. We've got a patient portal. So what do you think is different? What is enabling, if the patients have all those points of access anyway, what's changed? What's enabling those?
I can answer that. I know for some of them, and they've even told us, they will give you more information by text messaging, because it's not having to speak to you over the phone or in person, that they may give you more information concerning on what's going on in their health status that they may not feel comfortable to begin with, or they didn't feel, like you said, that someone cared and that somebody hasn't been checked in on, and that we might have just sent that check in and it reminded them, hey, my blood pressure has been running really high for the past 2 or 3 days, and they apparently care. So I'm going to respond back to that. And then they come into our office. We just had one of those happen today. So that was one of those where we're like, hey, we're just checking in with you, how's everything going? And then they're like, oh, by the way, I probably needed to go to the emergency room, or I almost did. But now that you're checking in with me and I'm responding back by text messaging, for some reason, people feel more open and more honest through text. So they provide more information that way.
Stephanie, it's interesting that you mentioned that, because before we started CCM, we had seen similar responses in terms of those social determinants of health that Lisa mentioned earlier. They don't want to tell the physician that they have food insecurity or that they have other issues ongoing, but they'll mark something on a piece of paper. I think it's just having to confront that or verbalize it is difficult, especially for our geriatric patients that are very prideful and independent. And there's something about being able to communicate that non-verbally that I think is liberating to a lot of them.
Yep. Echo all of that. And I would say it's frictionless. It's technology they're used to. They text their grandkids, they text their family members. It's easy. And somebody gets back to them that same day, and we then direct them, what should I do? So I've had patients say, I feel like I don't have to guess what I should be doing with myself or my health. that I can just ask a nurse and they can help me with what's the best next step for what I have going on. You know, I think people just need nudging sometimes. We had a person that was reporting, you know, shortness of breath, and she was like, well, I have COPD, I'm delinquent in seeing my pulmonologist, I'll make the appointment. And I tell my staff, get on the phone, do a 3-way call with a specialist, get the appointment set. We were able to convince her to come in, and she actually was sent to the hospital for a procedure. She had a blockage and was approaching a heart attack. So her shortness of breath was not due to her COPD, and they were, you know, the patient's trying to make these decisions or guesses on what's going on with their body, and they really don't know. So we've seen a number of those things that we've prevented really adverse events from happening by intervening quickly and just having that direct line of access.
Lisa, that's a great example. I appreciate you sharing that. I'm curious as to whether or not you've seen this situation where what we find is that the CCM gives us an opportunity to number one, capture revenue for things that we were already doing that we weren't getting revenue from before. But the other thing is just that better communication all the way around, that, you know, we may have missed an opportunity to take care of that patient or to address a need because they were frustrated because they couldn't get through on the phone line, or we were having to disrupt clinic. The nurses are busy and they were later in the day getting that phone call back. So this extra layer of that patient communication has been proven for us to be so invaluable. Plus it's adding a little extra income or revenue stream for things that we were already doing in the beginning.
Yeah, we've seen it. We've generated close to $600,000 of revenue in about a 13-month period. And that's still claims run out. So we've got a large number of patients engaged, and it's really, you know, just figuring out the productivity and the balance of all of that has been, you know, some work for us as well. But I think we found a good spot to be in. But yeah, it's added a huge opportunity. So because I'm in an ACO, I'm taking all of my claims data on my attributed patients that are in CCM and my non-attributed patients, and I'm going to compare the two cohorts and look to see, are my care gaps closed more? Are my admissions per 1,000 less? Are my ER visits less? You know, patient satisfaction, all of those things, and what are we being measured against in the ACO, and do I see those positive outcomes happening on the enrolled cohorts? And I think that will then also increase the physician's likelihood to think, oh, that person should be in CCM. Everyone with 2 or more conditions should be in CCM, and sort of help with that other type of enrollment versus just me outreaching the patient. So we're starting to look at that, because I think it's important for the providers and also for our health system that we are providing the service to the community that we say we're providing, that, you know, the outcomes match the words, if you will.
We are also in an ACO, so I will be very eager to get the same metrics and just see what the data reveals. I suspect that it'll be a trend in the right direction. At least I'm hopeful of that.
Yeah, we'll have to swap stories for sure.
Yes.
Thank you so much, both Lisa, Julie, Stephanie, for your insights in the points that you've made. And I know we've run long. There's been a really engaging discussion. We still have several people on the phone. I would love to hear from the rest of the audience, especially the folks that we're not working with. Other questions. What are other things coming to mind after you've heard this discussion? What are some challenges that you're running into? Eugene had a really good point about the physician buy-in. Other questions from you all as we wrap this up?
You can, if you want to speak, feel free to, you can press the raise hand feature. I can request an unmute, or if you just unmute yourself and speak up. I'm not. Yeah, we could also just sort of run a poll question here real quick. I know we're a little over time, but just I'm a little curious. We have these polls set up. How many folks, like what percentage of patients are you currently giving proactive care management to? So if you just see the poll that's up on the screen there and click and answer, can sort of see where people are at. Give it a couple more minutes here, or a couple more seconds rather. So got a good mix. Some folks are in the 0 to 10 range. We got some people in the 20 to 30, some in 30 to 40.
Yeah.
Certainly interesting to see people's different experiences.
Yeah, and Ben, this is in line with what I expected, especially the 0 to 10% crowd. And one question I have, and both Julie and Lisa are in charge of their efforts in their ACO. And one of the questions I know we get quite often from organizations that are participating in value-based care contracts is this percentage, like the percentage of patients that you actually need to provide proactive care management to. And the question is typically why, like the typical model is, and it's what the data shows here, it's going to be somewhere between 0 and 10%. The highest utilizers and the very highest risk patients. And let's just provide that care management to them because that's where we're going to get the biggest bang for the buck. You all have chosen a different model, and perhaps this is what you were doing before, but you've chosen a much more scaled up model of care management for your communities. Why did you choose that? Why was that important to you?
Well, I personally have been involved, I mean, really for the past decade in prevention, lifestyle, all the emerging science around aging. I mean, you can start whenever. And getting people to move towards healthful behaviors is really, you know, tapping into behavioral science and understanding what makes that patient tick so that I can get them to that healthful behavior. There's no way I could do that across thousands of patients, you know, with the resources that we have, or even going and asking, you know, can I hire 50 nurses? That would never happen. So, you know, really participating myself in health coaching and understanding what is necessary to get to that place. In the Medicare contracts, we're measured on benchmarks. So, you know, we need to keep every beneficiary below a certain percentage of spending based on their acuity of care. You know, one hospitalization can throw off the benchmark for a low acute patient that had a reason maybe they could have had that prevented. So anywhere I can generate savings is one, the right thing for the patient, two, the right thing for society. I mean, that's how I look at it, is we all pay taxes. So we need to be more judicious with our spending, and it needs to be more appropriate and more in the right place. The lower cost settings are often skirted over because there's not enough resources. I mean, primary care doctors are going to become extremely rare in the next several years, and it's going to become even harder. So I think this is how I see that sort of virtual extension, a virtual web of connectivity with our patients. And when your need pops up, we match you to where you need to be in that journey. So whether you're a low acute or a high acute, those high acute patients you're talking about, Darshan, they need a specific set of things. They need palliative, they need home care, they need a lot of help. And those things will reduce those costs, but there's a lot to be done in the middle prior to them becoming that high cost patient. So I see benefits across the board, regardless of where people are at in their health journey.
That's a great point, Lisa, in terms of the patient being proactive in their own care and teaching them those skills. I think that's a wonderful wonderful concept. I'm glad to hear that was one of your goals. Selfishly, that should have been one of ours, but one of our immediate attractions to the CCM was trying to reduce hospital admissions for these high-risk patients. That's one thing that I have to say about being in an ACO is having access to the data that Aledade provides us, lets us have insight to those high-risk patients so that we know where to focus our efforts. But kind of on a different line, and I may start a firestorm here, and I don't mean to do so, but for years we have been taught or preached that it's all about the patient. It's all about the patient, and it is all about the patient. I don't deny that whatsoever, but as our healthcare environment is changing, we have to start putting more emphasis on our employees. We have to make sure that we're giving them the attention, the skills, the tools that they need to be successful. And we're a fairly small practice. We have 130 employees or so. And we've always tried to say that we have somewhat of a family atmosphere, which I think is unhealthy in a lot of ways. Yes, we want to be family friendly. We want to try to be flexible and allow people to leave early to go to their kids' ball games and things like that. But we need to be unified with common goals. And those common goals need to be our patients. It needs to be patient care. And so one of the things that CCM has allowed us to do is alleviate some of that workload from our clinical teams because of the phone calls that they were getting bombarded with and having to disrupt their clinical operations to respond to these things that our patient needs. It's given us an ability or an opportunity to free up some of that workload and have dedicated people for that incoming communication that hopefully will allow us to unify once again around our patients and their needs. Because I'm hopeful that as we continue to get this positive patient feedback and these good comments coming in from our patients, that the entire team will recognize that, yes, it's a team effort and it's centered around our patients. That is our common goal. That is what unifies us. It's not that we're working as a family just internally from the employee perspective, but it's all encompassing. It's a team effort that includes the patient and teaching them the responsibility that they have to be proactive in their healthcare as well.
Really great point, Julie,
Great point.
about how centralizing this function actually frees up your clinical staff in the practices to do what they do best, and frees up their time. That's a really excellent point. Eugene, I know you've got your hand raised. Feel free to unmute yourself, and would love to hear your comments.
Well, I want to thank all you guys who've been talking, because it's so refreshing to hear people with really great success stories. And I could probably keep you full of questions for a long time, but I'm going to ask. I'll start with two real quick since we're at a low on time. The first is, have you guys found that you need to seek the waivers on the copays in order to be to really get the a higher level of patient engagement? We've always found that it's not even the 80-20 rule. It's more closer to 40% that will deny enrolling just because of the copays. And then the second question would be, have you guys started to incorporate better or a deeper behavioral health screening, more than just PHQ-2 or PHQ-9s, into your CCM?
On the co-pays, just because we've been up and running a little bit and we've addressed some of these things head on. So we, vetted through our legal team. We already had structured questions on financial need, if you will. So any co-pays that the patient can't afford, an office visit, what have you. What we're finding is about 85 to 90% of that 10% or the 20% copay is dropping to the SUPs. SUPs are picking it up. So we have very few patients that are actually getting that $8 or $10, $12 copay. And we did a very robust planning session with family in Q4 of last year, because I was anticipating this happening in January, February, March. And so we did a verbal consent campaign where we called every single patient and said, hey, we're just reminding you that you're in this program and that we do low Medicare. And, it's the beginning of the year. If you run into a problem with your bills, just call us. We'll talk through, talk through it with you. Like 99% of the patients were like, I know you're billing Medicare and I'm fine with that and I'm okay. And they felt good that we were upfront with them. So that we were able to tackle pretty easily. Remind me of the second question again. Sorry, lost my train of thought there.
The more advanced behavioral health screens.
Oh yeah. We're kind of doing that through social determinant screening. The way that I'm thinking about things is what community resources do I have? And that's where I'm going first, right? So if I know I have food trucks and I have food bank programs, I started with that. We did screen patients for mental health during May with mental health awareness. We structured our check-ins to find out if patients were struggling with anything because it changes all the time. And we actually had a number of patients just report issues with grief. So we were able to connect them with free grief counseling in our community. So I would say if you're going to venture into the BHI, which I know family is exploring sort of subsets of CCM, and BHI is one of the areas I'm interested in getting into, you kind of have to make sure you have your infrastructure set up so that when you turn the things on, you have places to put patients and you have resources for your care managers, because it will come up. And so you just want to make sure you have sort of that need or that resource for the patient there. So we have treaded a little lightly on that, but it is an area that I'm studying to figure out how do we implement. I think a social worker would be a great addition to this team. And that would be where I would start, because you can build the same financial model with a social worker salary as you can with an MA salary or a nurse.
We've really not run into the copay issue yet because we started small with only our Medicare patients that had a secondary insurance. Our plan is to slowly grow this and expand it to other opportunities. So we've not really run into the copay issue yet. And then on the behavioral health, because it's so new, we really haven't done anything more in depth. It's an interesting concept, and I'd certainly like to explore that. One part of our strategic growth is we plan to do a health fair later this fall, and it's mainly for gap closure. So it's kind of a VIP opportunity. We'll schedule an actual appointment for the patients, and we have Medicare Advantage plan reps here with goodie bags and things to help with that patient engagement, let them ask questions about their plan if they need to. We'll try to close gaps like the diabetic eye exams and things along those lines. But that, and those patients who need a good blood pressure reading that we've been unsuccessful at capturing all year, though that will be an opportunity for us to try to engage those patients who declined enrolling in chronic care management, as we're having those one-on-one in-person conversations, and they're seeing hopefully the benefit of all these proactive things that we're doing to try to take better care of them. That will be another plan in our strategic emphasis to try to grow the platform.
Wonderful. I know it's 1:36 Eastern time, and we've run over because there's been a lot of good discussion. I really greatly appreciate Lisa, Julie, Stephanie, you all for joining, helping answer the questions and give your perspective and your insights into the questions. Eugene, thank you for speaking up with questions and engaging. And for the rest of you, I hope this was helpful. We're going to be looking to do these types of interactive workshops regularly on a variety of topics. And so look out for the invites to those in the future. And again, greatly appreciate everybody's time. I know how busy you are, and we appreciate your support and engagement here. And I hope everybody has a wonderful week.